All right, our next speaker today is going to be Dr. Kyle Davis. He is a licensed clinical psychologist specializing in clinical health psychology and behavioral sleep medicine. He earned his PhD in clinical psychology at the University of Colorado in Boulder. He completed a specialized training in mood and sleep disorders, chronic pain and weight management at UC San Diego, and primary care mental health integration at the Center of Excellence in Primary Care Education at the Boise VA Medical Center. He works very closely with one of our local physicians, Dr. Jennifer Schall's, in the Lifestyle Medicine Clinic, where he does a lot of teaching and health education for behavioral change. Looks like you also do a private practice as well, is that correct?
Yeah.
Okay.
Yep.
Does private practice, specializes in treatment of sleep disorders, chronic pain, weight management, related to health conditions, and he's also one of our clinical providers for Ada County Medical Society's Physician Vitality Program. So big round of applause for him for doing that. So. In his spare time, when he's not teaching and thinking about sleep, he enjoys fly fishing, running, cycling, snowboarding, enjoying live music in Treasure Valley. So let's give a big round of applause for Dr. Davis. Thank you.
Oh, yeah. Yeah, thanks so much for having me. And so just to clarify there a little bit, I currently work half-time with the St. Luke's Lifestyle Medicine Clinic, and then I spend the other half of my time in my private practice, which is called Confluence Health Psychology, but I'm the only person there. So if you call, you talk to me. Just go ahead and click on the screen, then you can just. All right, so the other big part of that is I probably spend like 80% of my time these days, or clinical practice, treating insomnia. So this is something that I do day in, day out, and I really love it. And I guess just a little bit more about that. One of the reasons I love treating insomnia is the treatment is usually pretty straightforward, and we can help people improve the quality of their lives like relatively quickly in the world of therapy. Oftentimes in just a month or two, we can see really significant differences. So yeah, it's really rewarding for me to do that. I have no relevant financial relationships to disclose, and I've got a lot to cover because I was asked to cover non-pharmacological treatment of insomnia, or cognitive behavioral therapy for insomnia, special considerations for adolescents, and how to help people get off of medications for sleep. And I've got about 45 minutes to try to do that. All right, so first up, when we're talking about insomnia, we're talking about dissatisfaction with sleep quality or quantity, and people are having trouble falling asleep, staying asleep, or they wake up early in the morning and they can't get back to sleep. We kind of use a clinical cutoff of about 30 minutes for each of those things. And people are having significant distress or impairment during the daytime. Usually that means people are feeling really tired, or maybe they're feeling really sleepy during the day. Maybe they feel like problems with sleep are impacting their mood. They're feeling really down or irritable because of sleep, or they're having trouble getting things done or concentrating. Or they're feeling like their memories are causing them trouble. And this is going on at least 3 nights a week for 3 months. And people have enough time to sleep, they're just not able to sleep during that time. So insomnia is super prevalent, as you all probably know very well. So 35% of folks complain of problems with insomnia. So even here, we probably have close to 20 people that probably have problems with sleep right now. 15 to 20% of folks will meet criteria for acute insomnia, and then 10 people would meet criteria for chronic insomnia. So I've got a quiz question for y'all. And if you've seen me give this lecture before, you've seen this already, but insomnia is, I want to hear your all's best answer. So insomnia is typically the result of A, genetics. This is just something that you were born with. This is your lot in life. B, learned behavior. Somehow you have unintentionally trained yourself to sleep poorly over time. C, an overactive mind. If you could just slow your mind down at night, everything would be okay. Or D, chemical imbalance. You don't have enough melatonin, adenosine, or too much orexin, or something else is going on in your brain keeping you from being able to sleep. Show of hands, who thinks it's A, genetics? All right. B, learned behavior. All right, we're well trained. C, overactive mind. Okay, and then D, chemical imbalance. Okay, so this is kind of a tricky question because I think the best answer is B, learned behavior, but oftentimes having an overactive mind is the learned behavior. People have gotten used to being awake in bed, and then their mind has associated being in bed with being awake, and so that tends to happen frequently. So what do we do about all this, and how do we understand what's going on? So what we're looking at here is called the 4-factor model of insomnia, and it's really like a diathesis stress model. So first up, we've got predisposing factors represented by our little red bar. And predisposing factors for insomnia would include what we call a hyperarousability trait. It's easy for people to have a strong stress response. We see more prevalence in women than men. We see prevalence increase as people get older, also higher in people that have a family history of insomnia, people that are doing shift work, probably like some of you all have to do sometimes, higher prevalence in folks that have also been diagnosed with another mental health condition, higher prevalence for folks with sleep apnea, restless leg syndrome, periodic limb movement disorder, and then also people that are night owls that are kind of getting, if they have to get forced into more of a daytime kind of schedule, then they can certainly run into more problems with insomnia as well. But the main takeaway are, predisposing factors don't give you insomnia. They just make it more likely that you could develop it later on. So next up, we've got precipitating factors for insomnia. So oftentimes when people first start having problems with insomnia, they're experiencing some kind of increased stress in their life. Whether this is work-related stress or people are worried about money, relationships, health, all the normal kinds of things that cause people stress. Or they're experiencing changes in their work schedule, like they start doing shift work, could be associated with a traumatic event, and also like the diagnosis of new physical health problems or mental health diagnoses. All would be really common times that people first start developing problems with insomnia. So to summarize up to this point, everybody's got a certain amount of predisposing factors or risk factors. That in combination with some sort of stressor, change in somebody's schedule, results in them starting to sleep poorly. So now the person has acute insomnia. So a really important question is, what do people start doing differently whenever they start having problems with sleep? What do you all think people would be more likely to do if they had been sleeping poorly? Yeah, maybe they're turning to substances. So whether this is alcohol, marijuana, prescription medications, over-the-counter sleep aids. So that would be a really common thing. What else? Yeah, napping. So we'll call napping, throw that in with also going to bed early, sleeping in later. Once you finally do get to sleep, people start trying to catch up on sleep wherever they can. What else would people do? Yeah, so maybe they start conserving their energy because they say, I only have so much energy to work with, and so, I can't exercise anymore. And, in more extreme situations, people's lives really start revolving around their sleep, and they're canceling meetings or obligations because they're afraid that they're not going to feel well enough to be able to do those things. And so one other thing, how do you think people's thoughts about sleep start to change if they're sleeping poorly? Okay, so they're stressed about it. And if they're stressed about it, they're probably, they're worrying about it. What do you think people are thinking about when they're lying in bed at night? Yeah, they're thinking about how terrible it is that they can't sleep. And if you're thinking about how terrible it is and you want to improve sleep, what are you going to start doing, you think? That's kind of a weird way to ask that. Think of something else. Okay, maybe you try to distract yourself. But I think what most people are going to do is start trying harder to fall asleep. They think, what do I need to do to make myself fall asleep right now? And, so we see a lot of really smart, hardworking people that develop really significant issues with insomnia because whenever they are confronted with different problems in their lives, what do? They've learned to work harder to get through those. How well do you think it works to try harder to sleep? Now you all are like really hard workers and really smart people. If you all gave your best effort to fall asleep right now, how good do you think you could do? You're like, if you like, keep talking, Kyle, maybe we could fall asleep. But the main point there is you can't just apply effort and make yourself fall asleep, and that's really where a lot of people get stuck. So all these different things that we're describing are what we call perpetuating factors for insomnia. So these are really natural things for people to do when they haven't been sleeping well that can end up causing them a lot more trouble. So some other things that go into thoughts about sleep would, sometimes people have really unrealistic sleep requirement expectations. They say, I need to sleep 8 hours a night. Dr. Oz said I need to sleep 8 hours, and that's not happening. Something's really wrong with me. They think something else is causing their problems with sleep. Oftentimes, when people are feeling tired during the daytime, they think that that's caused by poor sleep or lack of sleep. And it could be a number of other things, even including the medications that they were using for sleep in the first place. Or another really common issue would be depression. People think they can try to sleep themselves out of depression, and it just doesn't work that way. And then other things that we're kind of getting at is when people start giving themselves more time to sleep, they also start spending more time in bed awake. And oftentimes people are laying there worrying about things. Maybe they're worrying specifically about their sleep. They start trying harder to sleep. Maybe they're doing things like reading or watching television or scrolling on their phones. But the bottom line is they're spending more time in bed awake, and that can make problems with insomnia worse over time. So next up, after people have been engaging in these perpetuating factors for long enough, they tend to develop what we call conditioned arousal. And conditioned arousal can be described as a learned expectation to be awake whenever people are in bed. So the more time people spend in bed awake, feeling alert, feeling frustrated, feeling anxious, the stronger that association is going to become between being in bed and being awake. So this is why people oftentimes feel like, maybe they're watching TV at night and they're feeling really sleepy and they say, all right, I finally get to go to bed now. And then they get into bed and they feel wide awake. And they're saying like, what's going on? Like, why am I wide awake when I was just feeling so sleepy a few minutes ago? And unfortunately, their brain thinks it's trying to help them out. It's doing what it's used to doing. It's used to like laying there and processing the day, planning the next day, thinking about all the things that they have to get done, how they're going to be affected if they don't sleep well. And when you do that over time, it becomes a conditioned response to being in bed. So any questions about the four-factor model before I move on? Does that generally make sense to folks? Okay, so now I want to talk about the different forces that regulate our sleep, and we're going to use this to kind of inform how we go about treating insomnia. So first up, we've got process C, or our circadian rhythm, and as you all know, our circadian rhythm is responsible for all sorts of different things. Our circadian rhythm is controlling when we feel sleepy, when we feel alert during the day, when we feel hungry, regulating when we're secreting different hormones, and definitely plays a really important role in sleep. And then what people are not usually as familiar with is what we call process S, or our physiological drive for sleep. And I think about this a lot like I do hunger or thirst, in the sense that the longer you go without eating food, the hungrier you would get over time. The longer you go without drinking water, the thirstier you get over time. And the same thing applies for sleep. The longer somebody goes without sleep, the more pressure for sleep their body is generating. So when these processes are working well together, I think this graph really kind of speaks to that. So let's talk about sleep drive first. So I wake up at 7 a.m. in the morning. All during this time that I'm awake, I'm building up more sleepiness. In this case, I go to bed at 11 p.m. I burn off all this sleepiness, and then the process repeats itself again the next day. We can think about circadian rhythm in this case as representing how hard our brains are working to keep us awake. So when I first wake up in the morning around my normal time, my brain's not working hard at all to keep me awake. It doesn't have any sleepiness to fight against. as the day progresses, it has to work harder and harder to fight against that accumulating sleepiness. And then when I get close to my bedtime, there's a big drop off in these alerting signals, or in the absence of bright light. And this presents an ideal opportunity for somebody to fall asleep when they've got all this sleepiness, and then their brain's not working to keep them awake anymore. One other thing I'll add there, this may be relevant right now, there's a little dip in our circadian rhythm, a little bit, or probably a little bit earlier than now, usually kind of early after, probably like 1, 2 o'clock for most people after lunch, when there's a dip in that alerting signal and you feel a little sleepy. That's your circadian rhythm just not quite putting out as much as it was earlier. Then it kicks back in and usually carries people through the evening. So any questions about how those two things would work together?
What's the reason for the dip at 1 or 2 p.m.? Are we naturally, should we all be napping?
Perhaps.
Can you restate for the online audience?
Oh yeah, so the question is why do we have this postprandial dip in our circadian rhythm? And that's a really good question. I don't have a great answer for that.
Do the Spanish have it right with their afternoon siesta?
Perhaps. Where this is leading us is into the question of like, how are humans supposed to sleep? Are you supposed to get like one big chunk of sleep at night? Are you supposed to sleep in shorter chunks? Or, like, I'm sure some of you have read about the pattern of sleeping where you sleep for like 3 or 4 hours, you're awake for 2 or 3 hours in the middle of the night, and then you go back to sleep for another 3 or 4 hours. And I don't think anybody knows what the right way to sleep is, but it is really interesting that there's this drop in these alerting signals. And yeah, I don't know what that's about. Maybe we are supposed to take naps, but definitely our society is not structured very well for being able to take afternoon naps. So we'll put that aside for now. So the other thing that I really want to talk about are different types of arousal that can interfere with these processes. So, problems with insomnia can have to do with circadian rhythm. People are changing their sleep schedules. Like I have a patient right now who sleeps pretty well on like a 3:30 to 11:30 or like noon kind of schedule, and they have to start working at 9 a.m. on Monday. And so we have like a fast track schedule for her to try to shift her circadian rhythm, which is not going to be easy, but it's possible. Anyways, the other main things that can interfere with this are different forms of arousal. So first up, there's physiologic arousal. So this could be like physical sensations. You're in pain, you need to go to the bathroom, you need to roll over and get more comfortable, you hear a loud noise, there's a flash of light, something like that. So we need the capacity to be able to override process C and process S to wake up to different things going on in our environments. I think we can also make an argument that we need the capacity to override these processes to problem solve, or what we'll call cognitive arousal, thinking a lot about things. So you can imagine if you were in a survival situation, a really stressful situation, you may definitely need to stay awake in order to figure out what you are going to do to respond to that situation. So it makes sense from that kind of perspective. The problem is that can easily get extended to things that we're not going to save our lives by solving a problem about. Like when you're thinking about your problems your kids are having at school, or problems that you're having at work, or your parents, or like these other kinds of stressful circumstances, your mind will respond to that in the same kind of way as it would another kind of situation, where it will override sleep to try to do that. To figure something out, but oftentimes there's just no solution that's possible to figure out. So this becomes a big issue for people that are having problems with insomnia. So I think probably, primarily when folks are having difficulty, probably some mismatch between their sleep drive and how much time they're giving themselves to sleep. And they're probably also experiencing some cognitive arousal. They're just wide awake whenever they're in bed at night. And usually they're thinking about things during that time. They're not like relaxed, not worrying. At least that doesn't happen with the patients I see. Okay, so let's move into talking about cognitive behavioral therapy for insomnia and how it targets these different factors that can drive insomnia. So first up, one of the things we do is sleep efficiency therapy, which I'll go into more detail in just a minute. But sleep efficiency therapy can target circadian disruption as well as this homeostatic disruption, or sleeping more on different nights, or sleeping different amounts on different nights. And then circadian disruption would be going to bed and waking up at different times on different days. Next strategy, stimulus control. We'll target arousal and also this homeostatic disruption. And then cognitive therapy, counter-arousal or relaxation strategies are targeting arousal. And then sleep hygiene, which y'all are familiar with, is also targeting arousal. But you can see that that's just one little component of the treatment. And, you know, to be honest, like the patients that I usually see have excellent sleep hygiene. They're doing all those things right, and it's just because that's not what the problem was in the first place. It's very rare that I get to tell somebody to stop drinking coffee in the evening. And when you put all those things together, that's cognitive behavioral therapy, and that's how we target chronic insomnia. So let's get into these different aspects of treatment. So sleep efficiency therapy is probably, in my mind, I don't want to say most helpful component of treatment, but it's really necessary. And this is also what's different than what a lot of people have heard about just normal sleep hygiene recommendations or not spending too much time in bed awake. So what we do in sleep efficiency therapy is start off with having people keep fairly detailed sleep diaries, where you have them keep track of when they go to bed, their best guess for how long it takes them to fall asleep, their best guess for how many times they wake up during the night, how long they're awake during those times, what time they wake up in the morning, what time they get out of bed, any naps during the daytime. And we use all that information to see how much sleep they're getting per night on average in a 24-hour period. And then, as well as how much time they've been giving themselves to sleep. And then I'll make a recommendation for a sleep schedule that's a close fit to their current sleep ability. I've gotten nicer with this as I've been doing it longer. And what I usually do is take somebody's average amount of sleep, give them an extra 30 minutes. So let's say somebody's sleeping 6.5 hours a night on average. I may put them on a 7-hour sleep schedule. I'm going to ask them to pick one time to be up by every single day. We count backwards and set a bedtime for them. And then we start talking about what are you going to do to stay up until this time, and how can you feel as sleepy as possible by the time your bedtime's coming around. And we always want to make sure that people feel sleepy by the time that they're going to bed, even if it's past the bedtime that we have set for them. Initially, our goal is to help people consolidate their sleep, improve the quality of their sleep, start treating their symptoms of insomnia. Our expectation is people are going to be sleepy during this time. And I tell my patients if they feel really sleepy throughout the week and they're like cursing my name, then we're on the right track. We're trying to make them super tired because if we can make them really sleepy, we can treat their insomnia. And then what we're going to do is start adding time back into their sleep schedules. So if I started off somebody on that 7-hour sleep schedule and everything went according to plan, the following week we'd have them going to bed 15 minutes earlier. Usually I add time in on the front end. Sometimes we'll let them sleep in a little bit later. And we keep doing that until they arrive at a sleep schedule that's a good fit for them. They're generally feeling good during the daytime and they're not having significant problems with sleep at night anymore. Any questions about how sleep efficiency therapy would work?
How do we define how much time somebody really needs to sleep?
Oh, that's a really good question.
Can you repeat that?
Yeah. So the question was, how would you know how much somebody needs to sleep? And I'm so glad you asked that because people just get numbers set in their minds about how much sleep they need to get. And I don't have this slide in this presentation, but there's a really nice graph of the average amount of sleep that people need that tracks really closely to a normal distribution. So you've got about 2/3 of your population that are going to need 7 to 9 hours of sleep per night. But you've got some people out there that need more than that and some people out there that need less than that. And for the people that need less than that, they can't make themselves sleep more than their body is able to produce sleep. So the best way that somebody would know that they were getting as much sleep as they needed is how they're feeling during the daytime. If people are not feeling excessively sleepy during the daytime, they're not having to use caffeine, get up and go on a walk to keep themselves awake, then chances are they're getting as much sleep as they need. And that becomes a really important piece of education in the treatment because people are just shooting for numbers that, and that I think oftentimes people will get a number stuck in their head from an exceptionally good night of sleep, and they'll say, you know, I think I need 9 hours of sleep because that one time I slept 9 hours, I felt great the next day. And oftentimes that 9-hour night was like years ago, you know, and they're like chasing that really good sleep. And, you know, what I try to explain to them is oftentimes what had happened in that situation is they had been sleep deprived on previous nights. So they had built up a lot of extra sleepiness. They get this one night of good sleep where they sleep more than their average, and then they think that that's how much sleep they need. But in reality, it was well above their average amount of sleep. So that's something that I love teaching people about because it can be incredibly helpful when it comes to managing insomnia and finding a sleep schedule that's a good fit. Because people are just shooting for these numbers, and everybody's going to have their own unique sleep ability, even if most people are in that 7 to 9 hour range. All right, any other questions about sleep efficiency therapy? Yeah.
Do you let people use their smartwatches to record their sleep?
Sometimes. That's tricky. So there's a new disorder called orthosomnia that's characterized by obsession over fitness trackers. And I recently had a patient who this is totally happening to. He's an athlete. He pushes himself really hard. He tracks everything he does, nutrition, all of his workouts. He pays super close attention to his diet, alcohol intake, all these factors. And so we started talking like, oh, maybe it would be interesting to track your sleep. Now he's finding himself in bed, you know, just ruminating or obsessing over his fitness tracker data. And so he made the decision. He's like, I'm just gonna stop doing this. And I said, that is a great idea, because he developed a new problem by being obsessive over that tracker data. Anytime somebody has a fitness tracker and it's not like really stressing them out, I think it's interesting to compare those numbers to their self-reported numbers, but I always am going to encourage them to try to keep track of it themselves. I think it's probably only a matter of time, probably a couple years, before these trackers are as good as like in-lab sleep studies in some ways, at least in terms of telling when people are asleep or not. But we're just not there yet, and so that's a really good question, and it's nuanced, because for most people it's not going to make a difference, but for some people that really obsess about that data, you know, they're like, people will come and say like, I'm not getting enough REM sleep, and you say, well, how much REM sleep do you think you need? Well, I don't know, but I don't think it's enough, and so then they're like trying to will themselves to get different amounts at different stages of sleep, and there's absolutely no way that somebody could really do that. All right, any other questions about this? This is fun. Okay, so let's talk about our next aspect of treatment. Do nothing in bed but sleep, and sleep nowhere but the bed. And Lisa was asking me about this earlier. She's like, hey, I heard that if you wake up during the night and you're having trouble getting back to sleep, you should get up and do something else. And like most of this stuff, it also gets more nuanced. You know, generally speaking, we'll say, you know, if you're awake in bed, you just feel wide awake, or you've been there for more than 15, 20, 30 minutes, you know, you're tossing and turning, you're starting to feel frustrated, that's going to be a good indicator to get up and do something else that's boring or relaxing. Wait until you feel sleepy, go back to bed and try again. But another situation would be somebody who's like, let's say you're really not stressed at all. You're just laying there relaxing, you feel peaceful, you know, it's in that kind of situation, I don't really have as much trouble with having or letting people stay in bed, because there's no emotional association with laying there compared to somebody who's feeling really frustrated or stressed while they're laying there. Does that make sense? Because when you're thinking about that association between being awake and being in bed, the emotion associated with that is going to be really important in terms of whether or not that's causing somebody problems or not. Now, I'm not going to recommend, you know, that somebody pick up their phone in bed and start reading the news or something like that. That's no good. And I had to let my kids make an appearance in the slides. The other thing I'll say about that, sometimes people just take that a little too far. You know, there are plenty of people out there that read in bed at night, watch television in bed at night, have absolutely no trouble with insomnia. So it's not like an inherently bad thing for people to spend time in bed awake. It's just become something that we start looking at more closely if people are having trouble with insomnia. And so, yeah, once again, you know, if you're not upset, you're not having problems with sleep, then hang out in your bed. That's okay. But when people do have this learned association with being in bed and being awake, we want to help them start associating being in bed with feeling sleepy again. So one of the main ways we're going to do that is only let people go to bed once they're feeling sleepy. We try not to use the bed or bedroom for anything other than sleep or sex if people are having problems with insomnia. And then we generally will have people, you know, if they're feeling frustrated, once again, been there 15, 20 minutes awake, we'll have them get up and do something boring or relaxing, wait until they start to feel sleepy again. Usually like reading something not too interesting can be a really good fit for this. Sometimes, you know, people will listen to audiobooks or things like that, which can definitely be fine. Sometimes we'll even have people like watch television shows that are not too interesting, and they can start feeling sleepy again while doing that. Some of you are probably saying, what? Like, what about blue light, Kyle? And the issue there is, you know, like if you had a screen right in your face, I would be concerned about blue light exposure. But if you're like getting up and going to the living room, you're on the couch across the room from your television, I don't think you're going to get so much blue light exposure from that's going to significantly disrupt your sleep during the night. And then we have people wake up at a regular time regardless of how well they slept, so that they can build up more sleepiness and use that on subsequent nights of sleep. One other like little caveat there, just to make everything more confusing and add more gray areas. Sometimes I'll just let people stay in bed and just have them sit up and read during that time, and that can work really well too. If people are afraid about getting up because their dog is gonna, you know, think that they're going for a walk or something, or they're gonna wake their kids up or somebody else, you know, they've got a reason why that's difficult. And then they can have them sit up and start reading until they feel sleepy again, and that can work just as well, most of the time, I think. And sometimes, you know, it's not safe for people to be up walking around during the middle of the night. If people are at fall risk, you know, then we definitely want to modify, you know, and have people stay in bed in that case. But we're literally changing the position that they would be in if they were trying to sleep. So we don't let them lay in bed and just you know, stay there. We have them sit up and change their position. So you're still getting that learned association between laying in bed and feeling sleepy. Does that make sense to folks? Okay. Any questions about stimulus control recommendations? Okay, so what are the other things we do to help people that are having problems with insomnia? So sometimes we'll use cognitive restructuring, where we help people think more objectively about the implications of not sleeping well. You know, so oftentimes people say like, you know, if I don't sleep well tonight, I'm gonna feel terrible tomorrow, and if I feel terrible tomorrow, I'm gonna bomb in my presentation, and if that happens, I'm gonna lose my job, and you know, and they can get quickly carried away by these unhelpful thoughts. And so we, you know, try to get at it, to look at it more objectively, like, well, you know, how many times have you felt this way? How many times did you lose your job in the past because of this? You know, what's likely to happen this time around? I also love using a strategy called designated worry time for people that are literally, you just have like racing thoughts whenever they're in bed. We'll have them set aside time, like 15, 20, 30 minutes to write down all the things that they're worried about well before they go to bed. And the idea is, if you're writing those things down, when you start thinking about them again later, it'll be much easier for you to tell yourself, thanks, brain, but no thanks. You know, I don't really need your help right now to remember these things because I literally wrote it down earlier today. And so you've got the confidence that is living somewhere else. I think about it a lot like I do a grocery list. Most of you probably make lists when you go to the grocery store, so you don't have to remember every single thing that you would need at the grocery store. And this is really the same kind of idea. You write down all these things so they don't have to live in your head because your brain is going to keep trying to remind you of them at inopportune times. And then sometimes for the right patient, we'll use a strategy called paradoxical intention, where you have them try to stay awake instead of trying to fall asleep. So like an interesting way to think about this would be, you know, imagine like you're trying, like if you're kind of like me and you're trying to watch a movie and you have a really hard time staying awake during that, or you're a passenger in a car and you can't keep yourself awake. Even though you're trying super hard to stay awake, it just gets harder and harder. So for the person who can't help themselves but trying to fall asleep, we'll turn the tables on them and have them try to stay awake instead. And then we'll definitely encourage people to use mindfulness meditation to learn to view their thoughts more objectively, kind of getting the same, converging in the same way with cognitive restructuring and mindfulness meditation, just like these thoughts are not true just because they're in your head. Other things we'll do, sometimes have people do relaxation exercises like progressive muscle relaxation, diaphragmatic breathing, different breathing exercises. We'll encourage people to do relaxing forms of yoga. And also sometimes we'll have people do guided imagery exercises. An important call out here is I don't have people do these things to try to fall asleep. These are all great things to do before you go to bed to help yourself feel more relaxed. When people are doing these things to try to fall asleep at night, it can start backfiring because they've got some attachment to the outcome that they're looking for. And when that happens, I think about this, like you've got this little part of yourself like watching from above, seeing if what you're doing is going to work or going to work. And you know, like, is this breathing exercise going to put me to sleep tonight? And whenever you have that investment in what you're doing, it's probably not gonna work out because your mind is actively, it takes cognitive energy to monitor that process, and then it's not gonna work. But if somebody's just doing it to relax, it could definitely work. But it has everything to do with their intention whenever they're doing that. Okay, sleep hygiene. You all have seen this stuff before, but we try to avoid trying to fall asleep. Like we said earlier, you know, you can't will yourself to fall asleep. We watch out for caffeine, afternoon, half-life around 6-7 hours. Watch out for nicotine, hopefully all together. Alcohol is interesting because it makes people feel sleepy initially, but will disrupt quality of sleep later on. We try not to go to bed too hungry or too full. We watch out for too many liquids in the evening. We watch out for napping during the daytime. And this is another one of those caveats for people that have insomnia versus people that do not have insomnia. Napping is not inherently bad. If you're having problems with insomnia, it could be using up some of your sleep drive during the day that you want to have at nighttime. So for people with insomnia, we do discourage napping during the daytime, but oftentimes, you know, once we kind of max out how much sleep somebody can get at night, especially in like older folks, we'll add in a short nap during the day. That can work really well to help people get through the day and feel good. We try to avoid watching the clock. If people are watching the clock during the night, it's kind of inevitable that you're playing the countdown game, thinking about how much time you have left before you have to get up, which in turn makes people try harder to sleep. We watch out for exercise right before bed. Try to give people approximately like 4 hours, especially for more vigorous types of physical activity. If somebody were like walking or something, I wouldn't be worried about that. But you don't want to do like interval training like in the hour before you're going to bed probably. And then we also try to avoid bright light in the evening so that your melatonin is not delayed. Things that can help promote sleep, using a bedtime ritual. I think I talk a little bit more about that on the next slide. Doing the same kinds of things before you go to bed every night. Keeping your bedroom cool. Mid-60s is an ideal temperature for sleep for most people. Of course, we want to stay up until we're sleepy, keep a consistent wake time. We want people's bedrooms to be dark. We don't want noise or light to be bothering them. We're going to encourage them to exercise during the daytime and seeking bright light in the morning. One of the interesting things about exercise is sometimes people think they can work them or like exercise themselves into more sleep. And that I don't think is a great idea. I don't think you can do that. Because if you're training for a marathon or something, you know, then you would need like 16 hours of sleep a night or something to recover from that. So I think you can improve the quality of your sleep from exercise, but you're not going to just need a lot more hours spent sleeping if you're exercising. And as you all have probably experienced, sometimes like after really intense exercise, people don't sleep very well. It takes a couple days for that to catch back up. Okay, so some notes about wind down routines. It's not uncommon for people to be staying really busy right up until the time they go to bed. And so this is like really relevant for primary care providers. You have patients that are saying like, I don't know what I need to do to feel sleepy. And if you ask them what they're doing before they go to bed, oftentimes they're like watching the news or they're watching forensic files or they're reading murder mystery books or something, or they're checking their bank accounts, or they're sending off one last round of emails. And it's just way too stimulating to be doing those things and expect to be able to fall asleep easily after that for most people. So we try really hard to get people to commit to 30 minutes to an hour of wind down time before they try to fall asleep. So we've got a buffer between the busyness of the day and when they're trying to sleep at night. So once again, we'll have people do things like reading something not too interesting, watching television, like reruns of shows, like The Office can put me to sleep every night. Stretching, listening to relaxing music, taking a bath or hot shower can all be great kinds of things to build into the wind down routine. But like so many people are going to bed because they feel bored, their favorite program's over or something, and simply staying up 30 minutes later, doing something boring or relaxing can make a huge difference. The other thing I'll point out there, oftentimes people are going to bed based on their partner's schedule. So earlier we were saying people have different sleep abilities, but people have a tendency to go to bed at the same time and get up at the same time. So if their sleep abilities are significantly different, one of them is probably going to start having problems with insomnia. So if you've got, let's say, a 6.5-hour night sleeper and an 8-hour night sleeper, and they're following the same schedule, the 6.5-hour sleeper is probably going to be spending a lot of time in bed awake and can develop more problems with insomnia. So you may need to go to bed at a different time than your partner. Okay, so a summary of recommendations that y'all can give patients. I think the most important, it's so straightforward, but only going to bed when you feel sleepy. That can go a really long ways. Minimizing time spent in bed awake, getting up at a consistent time every day. This is super helpful because this is something people have control over. They don't necessarily have control over when they feel sleepy, but they do have control over when they make themselves get out of bed. We watch out for napping or dozing during the day. Use the bed and bedroom for sleep and sex. Practice good sleep hygiene and find a wind down routine that's relaxing for you. Not something that puts you to sleep, but just something that feels relaxing. All right, I've got one slide here about special considerations for adolescents. Probably the number one issue I see for adolescents are circadian issues. And then we get into the difference between delayed sleep wake phase disorder versus insomnia. So a lot of teens could do just fine on like a midnight to 9 a.m., 10 a.m. kind of schedule. But the reality of their lives doesn't allow for that. And so what we basically have to do is help them shift their circadian rhythm to be a better fit for their obligations, even though their natural tendency would be to stay up later and sleep in later. So some of the things we'll do sometimes are using bright light therapy. So if there's sunlight, that's great, but if not, we can use lamps used for seasonal affective disorder. You can also use a small amount of melatonin, and this is kind of way different than people usually use it. Like a 0.5 milligram 5 hours before bedtime with that bright light exposure upon waking can help shift their circadian rhythm to an earlier time. I really emphasize wind down routines and waiting until they feel sleepy to go to bed, keeping a consistent wake time as close as possible even on the weekends. I was working with a teen recently who I think he had to get up at like 6:30 during the school week. And we came up with a plan to have him get up by like 8 or 8:30 on the weekends, and that was kind of keeping things in check. So we gave him a little bit of leeway. That was working out well. And then another huge factor are different sources of arousal. Oftentimes, if teens can't sleep, they're grabbing their phones. And like my forensic files example was real. I had somebody who was like laying in bed watching forensic files when he couldn't sleep. And so we changed it to where he was reading his art history textbook, and that worked way better for him. And yeah, so we just want to minimize arousal, even though it's so tempting, to be texting with your friends or whatever. That's just going to turn their brain back on whenever they start thinking about their communicating with friends. All right, some notes about helping patients taper off medications. This slide is pretty dated now. This is over 10 years old, and it was just like shocking to me how often different medications for sleep are getting prescribed. And like one important note here, these are only medications that were approved by the FDA for sleep, and there are tons of medications that get used off labels for sleep. So like this doesn't include your trazodone or or doesn't even like amitriptyline or things like that here. These are just the FDA approved medications. So huge increase in prevalence of insomnia and people seeking medications over time. And I feel for you all because it's not the best answer to the situation most of the time, but that's what people are looking for. So I want to make sure I save some time for questions, so I'll keep this kind of short. And I'll just focus on the second question here. So if you prescribe a hypnotic or sedative medication to a patient, how do you typically prescribe that in terms of, do you say like, here's 20, make it last? Do you, like say, well, you're going to be on Ambien for the rest of your life? What is that normally like for y'all? And once again, I feel really bad for you. This is not an enviable position to be in. You probably wrote a prescription like this yesterday, right?
All of the above.
Yeah. Okay, yeah, just depending on the situation, you're just trying to help them out and get through it, right? So you don't have to answer that one specifically. But what happens when they've been using them regularly and they try to stop? Yeah, bad news, right? They're stuck. They don't know any other way to get themselves to sleep anymore. So let's talk about negative reinforcement. So back to your Psych 101 classes when you were learning about different forms of learning. So negative reinforcement is the likelihood to perform a behavior increases when a negative stimulus or outcome is removed, stopped, or decreased. So classic examples of this, like we learn to put on our seatbelts because we're trying to turn off that annoying seatbelt alarm. So I've got this annoying sound, I make it go away by putting on my seatbelt, and I learn that if I want to make that sound go away, I need to put my seatbelt on. Like in emotional eating, people learn to associate eating with other emotions. So they learn that whenever they're feeling bored, which is an unpleasant emotional experience, that they can eat to distract themselves and help them feel better temporarily. So they turn to food for that. They make that feeling go away. And then what they just taught themselves is, if I want to make an uncomfortable feeling go away, I can turn to food. Same thing goes with these medications about sleep or medications for anxiety. People learn that they can take a pill to make themselves feel differently, but that's all they learned. They didn't learn anything about managing the problem that was there in the first place. They just learned how they can make an uncomfortable feeling go away. So I think what plays out oftentimes when patients are using hypnotic medications, let's say somebody runs out of their medication, they're traveling, they forget their Ambien when they came up to McCall for the winter clinics or something, and they start feeling like really anxious and they start having problems with sleep. So now they're like worked up about it. And so they'll tolerate that for a little bit, but let's say they're trying to quit. I guess my example of running out wasn't good. Let's say that you had it and you were just trying not to use it, but then you get really anxious and then you take it. And immediately as soon as I take that, those feelings of frustration, anxiety decrease because I trust that this medication is going to rescue me. It's going to help me out. It's going to help me feel sleepy. And now their belief in and use of the hypnotic medication is reinforced because they said, well, I didn't feel sleepy before I took it, but when I did take it, then I started to feel sleepy again. So often, like what's happening is like they'll feel that way before the medication even has a chance to kick in. It's simply just learning that they can reduce their anxiety about it because they trust in it. So we're really talking about placebo at this point. They say, I don't have to do anything to sleep anymore because this medication is going to help me. And like we were talking about earlier, if you're trying harder to sleep, that backfires. And when people don't, or they have the medication, they don't feel like they have to try to fall asleep, and therefore they're better able to fall asleep. So how can we help people in these situations? And I take great pleasure in helping people get off of sleeping medications. So we use tapering schedules. So I pulled this from the VA. They've got all these great kinds of resources. So this is just an example of like a benzo tapering schedule. And the main idea when it comes to helping somebody with sleep is we really want them to increase their confidence in their ability to sleep. We want to help them learn how to feel sleepy naturally. And when that starts happening, once their confidence increases, then they're going to be in a great situation to start tapering off the medication. So the way that I typically go about this is not having patients change medications at all when we start CBTI. So we keep all the medications the same, and then they start seeing that what they're doing by changing their schedule, following the treatment program, that they start sleeping better when the medication stayed the same the whole time. And once they see that, and they see that they're improving their sleep strictly from what they're doing, then they feel empowered to be able to start tapering off the medication. So we do this really slow and steady. You can see, like in this case, like tapering off benzo, somebody would take a half dose of medication only 2 times in the first week that they were tapering, because it's not nearly as scary to taper off of a medication whenever you know that you get to take the full dose again the next night. And whenever that happens and they don't have all this pressure, oftentimes they find that they sleep just as well on a half dose as they did the full dose, which is really cool. And even then sometimes they like I'm looking at their sleep diary data with them, and they'll think that they slept better on the nights that they use the medication, but the nights that they use lower doses, they actually slept better. But they just have such a strong belief about it that we have to help them learn what's actually going on. So other things that recommendations we can make is, once again, stay up until you feel sleepy and wake at a consistent time, regardless of how well you sleep. So that's something that you all may be able to do, is recommending a sleep schedule that's equivalent to or slightly below the patient's sleep ability. So if somebody tells you that they think they need 8 hours a night, you could say, okay, well, why don't you follow an 8-hour sleep schedule with anticipating they're not going to sleep the whole time that you just gave them. And so you're going to create some extra sleepiness by following a schedule like that. And then they start feeling more sleepy, and then the medication starts working better sometimes. But it's really just their own sleepiness that you're bringing back to the forefront. We also, and then all of our other standard stuff, stimulus control, good sleep hygiene, and then an idea that I've thought about is prescribing medication with a tapering schedule in mind. So you're even with that first prescription, you could start with a tapering plan and say, this is how we're going to go about doing this, instead of, using it PRN. Because using it as needed is tricky, because people learn to save themselves with it, and then they start feeling desperate and they want more. So starting with the taper from the get-go can be super helpful. And then once again, we want them to build confidence before moving on to those lower doses, or they're just going to be more anxious about it. All right, well, actually, I did get through anything. So I was covering that last part really quickly. And so we can take specific questions about this, and then also just dive into general questions. Yeah?
So kind of that rumination, perseveration thing, association with early morning awakening. Some people get to sleep, but they wake up in the early morning, whether they have to go to the bathroom or whatever, and then all of a sudden they start thinking about the day. They can't get back to sleep. That's, at least in my practice, when I was morning, that's what I hear. Whether it's because of different things like job or kids or the stuff going on in our state or whatever it is, they have a hard time getting back to sleep.
For sure.
I don't know how to address that.
Yeah, so that's a situation where that designated worry time could really come in handy. So if people are giving themselves time to worry about those things, not at 3 or 4 in the morning, but probably in the afternoon or evening before they get there, where they're literally writing it down, then that person's now going to be able to say, oh yeah, this is the same old stuff. I've got time again later today to think about this. I don't need to do that right now. And then So like if they were doing that, then they would be able to change the way they were thinking about it. But the other kinds of things is we just try to direct people's attention into thinking about something more relaxing, more conducive to falling asleep. So maybe that's what your brain starts doing on its own. And then we could like gently guide it back to where you're thinking about those great powder turns you had at Brundage the other day. And so you start thinking about something else, and you're just, I don't know, it's kind of hard to explain, but just like gently guide your thoughts into something more relaxing. And so, but trying not to think about something usually backfires. So we try to focus our attention on thinking about something more relaxing. Gratitude, like during the daytime, is definitely something that could be helpful overall, but it would be different than like the designated worry time that I was talking about earlier. But yeah, even like you're saying, so maybe thinking about things you're grateful for. Yeah, that could be a great practice, and maybe even again, revisiting that in this early morning situation, and just thinking about pleasant kinds of things versus the problem-solving kind of stuff that your brain probably wants to do. Yeah.
I have two questions. One, should people who complain of insomnia be restricted from safety-sensitive work activities?
Not just because they're complaining of insomnia, because you'll see people that are sleeping 8 hours a night, and have no daytime impairment, but they're just worried about it. So it really, I would say if somebody is having trouble keep themselves awake, so I would approach it like you probably would sleep apnea. If they're feeling sleepy when they're driving or something like that, that's what I would be paying more attention to, but not just having insomnia in and of itself. You're going to end up with like 30% of your workforce that's out.
And my second question is the phenomena of being a morning person or a night owl, is that innate or is that a learned phenomenon?
I think it's innate. Because I see so many people that they say those patterns start so early on in life. Oftentimes they have a relative that was at a same kind of pattern. I think you can learn that over time, or it could be innate. But there are definitely people out there that are just natural night owls. And I think about circadian rhythm almost like a magnet. Like left to their own devices, they're going to drift back to that schedule unless they've got some reason that they have to stay on a different schedule. And so, yeah, I feel really bad for people in that situation. But it's not in and of itself a problem. It's just when it conflicts with other obligations.
One online question was, how long do these steps last before improvement or progress to another step?
Oh, I'm so glad you asked that. So like a typical course of CBTI is about 5 or 6 therapy sessions. So like those are like once a week. So like in the span of a month and a half, 2 months, oftentimes we're able to turn this around. It's not uncommon for me to meet with people 2 or 3 times before like they feel like they've got things under control, which is super cool when that happens.
Quick question. We as physicians spend a lot of our emotional energy in trying to convince patients to take medications for a particular condition that we're treating. What have you done for help that you might help us as physicians? We have lots of patients that come to us, they're on sleepers. Here we're trying to convince them to take medication. The paradox here, we're trying to convince them not to take a medication. And I think in a patient's mind, I've been successful with this drug. It's helped me. How dare you even consider to take this medication away from me, because all of these other medications, they create side effects and interfere with a lot of things, and now you want to take out the one thing that I found to be useful that you provided me. Again, it's a hard thing to do as a provider to help those patients even have any emotional incentive to try to get rid of this medication that's been helping them. In their perception.
Yeah, totally understand where you're coming from. I think as a provider, what you would do is draw on the workshop you had this morning, I think, motivational interviewing with Dr. Serio, where you're talking about why would you want to sleep more naturally in the future? How would that improve your quality of life? How could that prevent you from having problems with dementia or having a fall and breaking a hip, 10 years from now? And so, you start planting some of those seeds about potential long-term implications, which I know not everybody's going to care about, but you know, you try to sell them on the fact that they're going to be better off in the future without it. Once again, I'm not jealous of the situation that you're in, trying to convince your patients of that. Yeah, that's really tough.
This will be our last question.
I don't know if I could have a question, but, how many therapists in Treasure Valley are doing the cognitive behavioral therapy for insomnia, and how easy it is to get patients in with them?
That's an interesting question. That I think so. The way that I'll answer that is, you know, I think that there are people with a basic level of understanding of what CBTI entails. And there are very few people that have like extensive experience where they've been supervised by people that are experts in this kind of treatment. And I think like, so there are not very many. So myself being one of them, and like I just kind of fell into that whenever I got to Boise. It wasn't even my primary interest. It was just something that I knew how to do and could do well. So there really aren't that many. There is an insomnia treatment program at St. Luke's now that I started and then stepped away from a little over a year ago. And so some folks, you know, that are doing that with probably less specific training. They're more generalists, you know, that are also treating insomnia now. And then I know that there's one psychologist at St. Al's that's doing that, but I think she's in the rehab department, and I don't know if she sees people generally or not. Oh, what is her name? I just had it in my head until you asked. No, her name is Laura Burlingame Lee. There could be other folks that I don't know that are doing that. Oh, okay. Yeah, the STARS program is a whole nother thing. It's like a relaxation sleep hygiene kind of program where they're not necessarily doing sleep efficiency therapy or real CBTI, but some other components of it.
All right, well, thank you, Dr. Davis. We appreciate it.